Good morning, everyone. Thank you, Taryn. You were terrific. It's a great way to start off the meeting. Sorry. So my role today is to talk about the public health aspects of suicide, the patterns of risk, and the prevention landscape. So in terms of suicide, nationally, it's the 10th leading cause of death in the United States. The most recent data that we have is from 2016, which I'll get back to as a potential obstacle to suicide prevention. One thing to note is that among young people, suicide is the second leading cause of death. The rates fluctuate a bit year to year, but over the past 100 years, they've been relatively stable at around 10 to 13 per 100,000 with recent increases, as we are aware from the media and other sources. In terms of suicide rates by gender, what you often see with suicide data, it's presented typically, the rates per 100,000 are presented, as you'll see here. And this presents those data by age groups in years. And here you can see for males and females a different pattern of risk. For women, you see an increased rate per 100,000 in midlife. And for males, you see the same type of pattern, but you also see a really steep increase in young adulthood and at late life. And these are important developmental periods for suicide risk in thinking about the onset of severe mental illness and the onset of mental illness in general. At the early stages, there's quite a bit of literature showing that suicide risk is high in the early stages of risk. And also, according to development, folks tend to be more impulsive and have differences in decision making early on in life, which can contribute to their risk at this point. The other thing I want to mention is that there are several estimates of the costs. And the costs of suicide have to be mentioned in two ways. I mean, we've heard from Taryn about the toll that it takes on individuals and the toll that it takes on families. And it is a heavy burden. But the economic costs of suicide are also very substantial. And thinking about, for each suicide, what it costs in terms of lost productivity, which makes up most of the estimates that you see here from the Suicide Prevention Resource Center. In terms of methods of suicide, firearms account for the majority of suicides in the United States. So there is room for action on this front. In terms of firearm deaths, the majority of firearm deaths are by suicide, which is 60% of the firearm deaths. Most recently, there is cause for excitement in terms of thinking about extreme risk protective orders, which are relatively new. In 13 states in the United States have passed legislation for extreme risk protective orders, which would give family members, first responders, and healthcare professionals the opportunity to petition for removing firearms from those folks who are deemed to be at risk through violent behavior or other behavior that comes to attention as at risk for suicide. Some of you may be familiar with the recent results out of the Centers for Disease Control by Deb Stone and her team, looking at two sources of data. One was the National Vital Statistics System, and the other was the National Violent Death Reporting System. And I'm going to focus more on the National Violent Death Reporting System data. She reported on these data from 27 states. And the interesting about this source is that it examines demographic features and contributing circumstances to suicide among people with and without known mental health conditions. So in terms of suicide, the most recent data in 2016 that's available nationally is that there were around 45,000 suicides. Dr. Stone's team also reported that in many states, more than half of states, the rates were increasing by 30% or more. The other thing that most importantly, one thing that this report highlighted, according to the National Violent Death Reporting System, is that 54% of people who died by suicide did not have a known mental health condition. And when I saw that, I said, wow, that contradicts the evidence from psychological autopsy studies. And I think they're both important pieces of information here. This is sort of indirect assessment because much of the data that is part of the National Violent Death Reporting System is not actively asking folks about psychiatric disorder. It's if it's present, then it's included. Whereas for this study by Kavanaugh reports well over 150 psychological autopsy studies. It's a synopsis or what we call meta-analysis across multiple studies. And what they report fairly consistently across cultures and across studies is that suicide is linked with psychiatric disorder very strongly. At least 90% of folks who die by suicide have at least one type of psychiatric disorder at the time, whether it was diagnosed or not. And so this consistency of evidence across studies, I think, is important. But also, it's got to be somewhere in between the actual number, because when family members are reporting about their loved one they lost to suicide, they may be thinking about their condition and may be over-reporting to some extent, could be, the extent of mental health concerns that individual had. This study is hard to see, and I apologize for this slide. It's just to show that the disorders that have been really linked with suicide attempt, and also Annette Boutrey and her team has reported looking at suicide attempt and what proportion of suicide attempters have a psychiatric disorder. And she reported around 90% as well, which is consistent with the what I just presented from psychological autopsy. But this study by Bolton looked at the NESARC data, which is national data in the United States, and what they did is they looked to see which psychiatric conditions were most strongly linked with suicide. They reported nicotine dependence, post-traumatic stress disorder, major depressive disorder, and borderline personality disorder as being the most strongly linked. And across these studies, one thing that they look at is the proportion of these. They reported it in terms of population attributable fraction, which is the proportion of potential suicides that could be reduced if these conditions were not there, if they were prevented or treated or they didn't occur, which is a nice metric for looking at, similar to the attributable risk. This study here is also a very nice study that has looked at after a suicide attempt, which psychiatric conditions are most strongly linked with suicide death. And this is looking at 30 years of population-based data from Sweden. In Scandinavian countries, they have registers that where data are combined and can really give a broad picture of the burden of suicide and suicide attempts within the population. And this is one example of a study that did that. And what they did, they looked across the disorders that you see here: alcohol abuse and dependence, other depressive disorder, personality disorder, anxiety, bipolar and unipolar depression, and schizophrenia. And among men, you can see those lines. Let me see if this will let me. Oh, here they are. So the risk is really great in the first couple years after hospitalization. And this is a fairly consistent finding in the field that after somebody comes to clinical attention or is hospitalized, their risk is great after that treatment episode. And here you can see that unipolar and bipolar depression and schizophrenia, the risk was really great for these conditions, more so than some of the other conditions I mentioned. And for women, you see the same pattern, but the risk isn't as great. More recently, there's been some really interesting results from economists, Case and Deaton. And what they found is they were looking at mortality over the course of time, showing that the cohorts that were born in around 1950 and entered the workforce in around 1970 or so, that cohort and the subsequent cohorts were at higher risk for suicide, and especially those who had a high school degree or less, which can point to the potential epidemic, the toll that the economic conditions may have on suicide risk among individuals, especially if they do not have that academic background. In terms of public health and systems level initiatives, the Air Force Suicide Prevention Study has been one that gets a lot of attention in the field. And this was a strategy that was fairly comprehensive. There were 11 components to this that were rolled out system-wide. And here, this lists for you some of the strategies that were implemented. The one thing that I want to point out with this study that has relevance to a lot of other studies in suicide that are more systems level or population-based large-scale impacts is that oftentimes these programs show an impact. Here you can see that the suicide rate in the Air Force was around 16 per 100,000. And then the program was introduced and rolled out, and the rate decreased. But then in 2015, the rate came back up to what it was, and even higher than what it was before it was introduced. And not that this program was taken away, it's just that there needs to be, with these types of programs, attention to implementation quality, and a continued investment in these types of approaches and monitoring and mentoring of impact and so forth, which is important. Another study that is really terrific that comes out of the UK looked at mental health services. And similar to the Air Force study that I just mentioned, it looked at introducing across these settings these evidence-based approaches, like assertive outreach team, 7-day follow-up, criminal justice sharing of data and information, and so forth. And these were evidence-based approaches, and mental health service systems were encouraged to introduce as many of these as possible. And what they found when these were introduced is that those services that had implemented 7 to 9 of these had significantly lower suicide rates than those implementing fewer. And so it does reinforce the point that those evidence-based approaches, if they're rolled out and used, they can have an impact on the rate of suicide across these settings. Some of them appear more effective than others, and those of these were the 24-hour crisis team that would kind of run to the scene and be able to address right then and there someone in crisis and families in crisis and so forth. Managing patients with dual diagnosis, so these are folks that have both mental health and addiction concerns, and multidisciplinary reviews. And this is when a team would go to a family after a suicide and they'd meet with the family and so forth. And they would review records and they'd discuss and they'd figure out sort of like an after-action plan. Okay, this happened. How can we make things better in going forward? How can we improve the quality of care that we give families and improve what we do? And I feel that those types of reviews are very impactful on clinicians and seem to make a big difference. The reason why, in terms of the mental health, community mental health, the reason why this is especially important, and this study points it out nicely, what it does is it looks at the suicide rate, which is here, as you can see, going up, and then it looks at the number of psychiatric beds in the United States, which is going down. And as the suicide rate's going up, you see the number of psychiatric beds we have nationally going down. So there's more of a movement to mental health being done in the community rather than in a hospital-based, inpatient psychiatric setting. So it's especially important to have programs in place and to have high quality of community-based mental health services. I'm not going to say much about the Zero Suicide program, which you'll hear quite a bit about lately, but this also shows the value of being able to implement hospital-based, evidence-based strategies across hospital-based settings. And this just shows a little bit of data from the Henry Ford Health System showing when you introduce these evidence-based approaches, the impact that it can have in a healthcare system on the suicide rate, which is really substantial. One area that I've been really focused on is how do we use data to better inform suicide prevention? And a huge initiative in the field has to do with predictive analytics and being able to use data that we collect anyway, that we invest tons of resources in, to actually do something for action. And this, I think, is a very exciting development. You see, when I reported the data earlier, I sort of said, oh, this disorder is linked with suicide and this other disorder. But oftentimes what we haven't done as a field, and Franklin pointed this out beautifully in his paper that was fairly recent, is that we really need to be looking at not just one isolated outcome at a time, but the combined impact of risk and protective factors together. And if we can get data sets together to be able to do that, it should make us better at suicide prevention. So a lot in the field, people are using these data types approaches to try to predict risk and to try to improve the prediction of risk over time. And this can be helpful to identify those at risk, but if we can, there's all privacy, of people's privacy that we have to respect. And so thinking about if you can identify risk, then what do you do? And if they're a patient within your healthcare system, that's one story. But if they're not, and they're a community residing adult, you can't just necessarily send somebody out to the house unless you... So anyway, there's some challenges involved in using data for risk prediction and how to intervene with individuals that are not within your clinical care. So it's something to think about as a field, but it could be impactful. The other thing that these data-based approaches allow you to do, if you can get the data together, is to look at which interventions are most impactful, which policies, which treatment programs, which interventions seem to make a difference for folks. And I just wanted to point out some of the groups that have been focused on doing these predictive approaches. It's been done in the VA system, in Army STARS group of active duty folks. They've also been able to use this type of approach, and it's been done in healthcare settings with the mental health research network and so forth. So it really is an approach that's gaining some momentum, but with lots of challenges that will come up the pike for us to think about. Another area that I feel is really important is getting upstream. You saw when I showed you the rates for males, you see that spike that goes up from age 20 to 24, and the idea that maybe we need to invest in prevention. Just a couple studies that are worth pointing out that have really used CBT-based approaches, and one with medicine as well, looking at depression and anxiety and targeting those two big risk factors for suicide. And if you can make an impact and reduce depression and anxiety, these studies have shown that you can reduce future risk for suicidal ideation and attempt. And these were studies that were done in childhood and adolescence. There's another set of studies that have intervened early in schools and in primary care settings. And they have shown that if you can implement universal programs that are evidence-based early, then they can have an impact on suicidal ideation and attempt over a decade later. And then other nice thing about these studies and these interventions is that they can really be nested within a setting, and they can be done as the way people just do their jobs, much like some of the zero suicide work that you'll hear about. And they have shown to have cost savings. Another set of programs, another reason why I think these programs are important is that they don't just impact one, like the good behavior game and some of the youth aware of mental health and some of these other programs, is they impact multiple outcomes. And in terms of the good behavior game, it was shown that for every dollar invested, there could be as much as a $65 gain in terms of the value of this intervention with high school graduation and other benefits that individuals will have from these types of approaches. Restricting firearm access has also consistently been shown to reduce rates of suicide. The other types of programs that seem promising are programs that focus on maltreatment, like early home visitation model type programs, and laws that impact families, like divorce and child custody. There have been consistency and evidence in showing that these types of approaches affect suicide, but can also affect violence and other types of outcomes. So as a field, in terms of public health approaches, those approaches that are comprehensive, that are system-wide, seem to show that they could have an impact on suicide. Oftentimes, these are based on funding, and then when the funding is over, the impact disappears. So what we need to really do is embed these programs into how we do our job, in schools, in healthcare, and in other settings, in order for them to be sustained. But we also need to pay attention to the quality of implementation and the continued investment and excitement for these programs and continuing them on. As I showed from the Title Mom study from Sweden and others, lots of evidence that there are these high-risk periods that occur during the course of people's conditions with severe mental illness and overdevelopment. And supportive contacts after medical care seem as if it could be a real important approach in terms of folks returning back into the community. And peer-to-peer approaches have been used quite consistently in the addiction realm, but these are approaches that I feel could also be really beneficial in terms of suicide prevention. Thank you, and I'll stop here.